During the first 30 days of inpatient rehab, a patient's nervous system is often under immense tension. Untreated physical discomfort, poor sleep, and physiological stress can cause that resilience to fail, snapping strand by strand. This physical dysregulation is a primary driver of early dropouts. We can mitigate these physical barriers by integrating torque release technique, or TRT, into the facility. This is a structured operational workflow designed to address neuromusculoskeletal tension without disrupting core treatment programming. Launching this model requires 4 prerequisites: your facility's existing baseline retention data, a daily master schedule, an active EHR, and a credentialed TRT provider. Formalizing this process allows clinical leaders to introduce physiological support without overlapping with primary medical or clinical services. It creates a defined structure where physical care supports the evidence-based therapies already in place. Every 30-day inpatient stay begins with a highly structured intake process. This administrative environment is where the physiological support protocol begins. Step 1 integrates the TRT assessment directly into the standard admission process. Here, the provider establishes precise baselines for the patient's current sleep quality, pain intensity, and stress tolerance. Because many patients enter care with trauma histories, this requires a trauma-informed consent protocol. The documentation explains that the intervention is low force and entirely voluntary, and that the patient retains the right to pause or discontinue care at any time. Step 2 addresses the logistical challenge of adding a new service to an already packed 30-day inpatient master schedule. This diagram illustrates care windows. We map brief TRT sessions into the narrow white spaces between locked programming. These care windows map exclusively to unstructured time. TRT sessions never replace or delay medical detox, counseling, or psychiatric visits. This specific scheduling cadence prioritizes consistency and predictability over treatment intensity. Utilizing these flexible microblocks prevents scheduling friction. Patients receive the physiological support they need to remain regulated without sacrificing a single minute of their primary clinical exposure. Moving into the treatment room brings us to Step 3, where the physical care is actually delivered to the patient. The TRT provider's physical action is limited to delivering brief, low-force, instrument-assisted neuromuscular skeletal adjustments. This Venn diagram shows the clinical boundaries. The left is primary recovery care. The right is physical TRT support. They overlap solely to drive patient retention. The TRT provider does not counsel on neurobiology, offer psychiatric advice, or claim to balance dopamine. Step 4 ensures accountability. Proving the value of this care requires daily documentation. Immediately following every 15-minute session, the provider logs specific metrics directly into the facility's existing EHR dashboard. The required data points include the date, presenting symptoms, a 1 to 10 pain and comfort score, sleep quality, and any observed physical barriers to group participation. This daily documentation transforms subjective physical complaints into trackable, objective data. The medical team can now use this information to monitor patient stability throughout the 30-day stay. Step 5 occurs at the critical day 30 mark, which officially signals the transition phase out of the structured inpatient environment. Prior to the patient leaving the facility, the provider completes a formal, documented discharge reassessment. We compare the patient's current sleep quality, pain intensity, and group participation rates directly against the baselines collected on day 1. If a patient requests continued physical support, the aftercare referral protocol is precise. They are routed only to vetted community chiropractors who understand the boundaries of addiction recovery care. Closing the loop with these comparative 30-day metrics allows facility leadership to determine whether the adjunctive service improved length of stay and operational stability, providing the data needed to guide future program decisions. This flowchart maps out a fully compliant end-to-end TRT integration workflow. You have now built 4 operational pillars: a structured intake process, frictionless block scheduling, compliant EHR documentation, and defined clinical boundaries. Take this specific blueprint to your clinical director. Identify exactly which open scheduling blocks in your current system can become designated TRT care windows. The ultimate purpose of this operational workflow is straightforward. When we help patients feel physically well enough to stay in the facility, they can engage deeply enough for evidence-based recovery to take root.